PCI and medical therapy versus medical therapy alone in chronic coronary syndrome, which is better? There is always a big discussion, so let us see what he says.
First of all, thankful to the CSI organizers for giving me this opportunity. I am Dr. Vivek Gupta in Apollo, Delhi, talking about chronic coronary syndrome, medical therapy versus PCI. As an interventional cardiologist, I would like to be, of course, in the favor of PCI, but there are few trials which we have to discuss and tell about information about that. So, how to go next slide? So then let us discuss first the optimal medical therapy. What are optimal medical therapy, and then I'll talk about the PCI, and then we'll discuss about it. 17.3 million people are dying every year due to CVD in the world. These data are important for the physicians, but of course we have to revise. All are educated, but this is only a revision. CSI is a revision. Correct. So 17.3 million is 1.73 crore people they die. 6 crore people about are chronic CVD in India. 4 million people have PID in India, and more young patients coronary artery disease, 3 times higher rate of reinfarction in Indian patients, more triple vessel disease, 2 times higher rate of mortality post-infarction. So this is the overall burden of coronary artery disease. Risk of MI, stroke and CV death increases in patients with high risk of CVD. Higher risk patients are insufficiently controlled, risk factors, suboptimal lifestyle modification or medical therapy, large area of risk of myocardial infarction. They actually stable patient can become unstable. The patient who will remain stable will be lower risk with optimally controlled factors, lifestyle changes, adequate therapy for secondary prevention, which mostly we are not in, and appropriate revascularization done already. MI, stroke or CV death is the first year post-MI survivor population. This is a very important slide published in the European Heart Journal 2015. 1 in 5 patients event-free for 1 year post-MI had an MI, stroke or CV death within 3 years. Of these 20% patients who experienced an event over 3 years, 40% had an MI, 18% stroke, 40% CV death. So very important. That means all stable patients will not remain stable for whole life to come. The myth of stable coronary artery disease: patients with chronic CAD are not necessarily stable all the time. That's why they've been named as chronic coronary syndrome by ESC 2019. Be aware of the patient residual skill, even if they appear stable and are feeling well. Clinical inertia can result in recurrent events. If you see the slide on the right side, history of CAD, primary event, stable, feeling fine, and suddenly they have a recurrence of the event or acute coronary syndrome. So chronic coronary syndrome, as decided or advised by ESC 2019, stable angina, new heart failure, suspected CAD, stabilized symptoms, less than 1 year post ACS or PCI, stabilized symptom more than 1 year post initial diagnosis. These are stable patients, and they have been termed as chronic coronary syndrome. What are the optimal medical therapy in CCS? Let us concentrate only on the vascular protection, because we don't want a stable patient to become unstable. We already know this patient will be on anti-anginal patients, of course. We're not talking about that. 4 pillars for the vascular protection is lipid lowering, blood pressure control, blood glucose control. Everybody knows it, but we have to do very rigidly in all our patients. And anti-thrombotic protection. This is very important. I'm going to concentrate more on the anti-thrombotic protection, which we know aspirin, dual antiplatelets, clopidogrel, ticagrelor, which we are using regularly, but is it enough? We don't know. So Charishma DAPT trial, which was published in New England Journal of Medicine in 2006, it showed that in a stable patient, addition of clopidogrel does not add to any advantage, did not reduce the risk of stroke, MI or CV death. Similarly, recent article published on ticagrelor in the Pegasus trial, New England Journal of Medicine 2015. Ticagrelor reduces non-fatal CV events but increases major bleeding. So ticagrelor is partially effective in reducing some CV events if you add upon the aspirin in stable patients. The current unmet needs from single antiplatelet therapy and dual antiplatelet therapy, MACE reduction is significant, but no significant benefit in CV death reduction, no significant benefit in all-cause mortality, no significant benefit in major adverse limb events. This is the limitation of the dual or single antiplatelet therapy. So what we need to have a dual pathway inhibition therapy. I'm adding these slides because this is relevant in my talk. So dual pathway inhibition, which includes anticoagulant, plus antiplatelets, both platelet activation and persistent thrombin generation in chronic CAD. If you see this slide, it's a very interesting slide. Acute phase, you have platelet activation, but in chronic phase, you may have a thrombin generation formation, which can convert a stable patient into unstable patients. And therefore, we have to be careful. If you see the intrinsic pathway of coagulation, factor 10 is responsible for activated factor 10 leads to prothrombin conversion to thrombin and thrombin to fibrogen, leading to clot formation. On the right side, you can see platelet activation, which is important for the acute coronary syndrome. But we need to have synergistic effect of anticoagulant and antiplatelet drugs providing complete vascular protection. What you're talking about is to keep the patient who is stable to remain stable. So the COMPASS trial published in New England Journal of Medicine 2017 to determine the efficacy of safety of rivaroxaban, which is the factor 10A antagonist, low dose rivaroxaban plus aspirin or aspirin alone. And they showed, and they clearly showed a very important benefit. 30,000 patients were randomized to rivaroxaban plus aspirin, rivaroxaban high dose at 5 mg or aspirin 100 mg OD, and antithrombotic investigation was stopped 1 year ahead of expectation in February 2017 due to overwhelming efficacy of the rivaroxaban 2.5 mg BD plus aspirin now. And they showed vascular dose of rivaroxaban, that is 2.5 mg OD, and aspirin significantly reduced CV death, stroke or MI, and this was quite significant. Therefore, this showed in efficacy that in chronic CCS syndrome, we need to have an addition of rivaroxaban significantly reduced secondary endpoints. But there was some increase in the bleeding, but there were differences seen in the fatal and bleeding was not there. COMPASS trial in PAD, peripheral vascular disease, also showed a similar 28% reduction versus aspirin in PAD, 70% chances of reduction in major amputation in PAD patient, peripheral vascular disease patient. Amputation were avoided in 7 out of 10 patients who otherwise would have lost a limb. So recommendation for the event protection, antithrombotic therapy should be added. Of course, class 1A indication is antithrombotic therapy in patients with CCS and sinus rhythm. Aspirin recommended, clopidogrel indicated only when aspirin resistance, and of course antithrombotic should be given in patients, published in European Heart Journal 2019. I'm skipping. Coming on to the PCI, we are interventional cardiologists. We are always biased. I would not say biased, but we try to find the good way of doing angioplasty. We reduce symptoms, of course help the patient, but there have been few trials which have caused confusion in the mind of physicians and cardiologists and interventional cardiologists also. So I'm going to discuss the pitfalls of those trials. So CAD management, PCI alone or PCI plus optimal medical therapy. Limitation of trials. Before I go into the trials, I would like to show you the limitations. Some studies with some small sample size, inclusion of patients with mild angina, exclusion of patients with severe angina, exclusion of patients with severe angina, exclusion of patients with positive stress test, exclusion of patients with severe coronary disease such as left main, underrepresentation of older adults and women. These are the limitations of these trials and challenges replicating the intensive medical supervision. So similarly on the right side, if you see, I don't have a marker, I don't know how to go. Okay, so existing clinical dogma, exclusion of patients with most severe symptoms. These are very important factors, which is limiting factors in these trials, which I'm going to discuss, and exclusion of those with most severe CAD. Courage trial, very important trial, discussed hugely, published in New England Journal of Medicine 2015. In the Courage trial, patients were randomized to receive either PCI or plus OMT or OMT alone. Of course, OMT is always there. Optical medical therapy is always a part of whether you do PCI or not PCI. And there was no significant difference in mortality was observed at any time. It was also found that whatever two treatment regimens was there, the mortality of the patient began to be mildly higher than that of non-population only 6 years after the treatment. That means Courage trial showed in stable patients don't do intervention. This was actually indirect, not evidence but inference. Similarly, ischemia trial published in New England Journal of Medicine recently 2020, NEGM 2020. Initial invasive or conservative strategy for stable coronary artery disease. Among patients with stable coronary artery disease, moderate or severe ischemia did not find evidence that initial invasive strategy, as compared with the initial conservative strategy, reduces the risk of ischemic cardiovascular death or death from any cause over a median period of 3.2 years. This again said that you may not be so aggressive in doing intervention. Strength and limitation. This is very important. Courage trial, ischemia trial. If you see number 5 point, PCI did not reflect the contemporary practice. Number 5 on the left side, Courage trial. PCI did not reflect the contemporary practice with advanced invasive diagnostic assessment, pressure wire, interval imaging, and stenting. Only 3% received drug-eluting stents. Only 3%. Ischemia trial, if you see low burden of angina symptom, 34% had no angina in the preceding 4 weeks. So these are basic major limitation of ischemia and Courage trial. Meta-analysis also showed, meta-analysis is very important. Many therapies, whether PCI versus OMT, short and long term, there was a benefit. Short term, especially, there was a benefit of intervention, but long-term therapy did not show any major benefit in this meta-analysis trial. So what are the guidelines? I'm not going to detail, but my conclusion, all stable patients may not be completely stable. It's a very important point. PCI has become widely used and highly effective to stable CAD. Advances in past 2 decades have led to the improved short-term survival rates, reduced heart attack occurrences, and decreased need of repeat procedure. And of course, most important is that this PCI leads to resolution of the symptoms much more than medical therapy. And moreover, PCI has shown potential in reducing the risk of outcomes compared to medical therapy, such as combined risk of all-cause mortality, MID, especially in the short term, especially 1 year. We are not following up for 5 years. Future direction, the PCI for managing stable CAD after promising opportunities for improving patient outcome. And the last slide, which is my personal slide, guidelines do guide you, but does not impose upon the treating cardiologist. They are only to guide you. Finally, you are the best treating physician. You know the patient symptom. You know the coronary morphology. You know how to treat it best. And therefore, don't get guided or imposed by the guidelines. You have to take a final decision in the best interest of the patient. I finally conclude that if required, if there is triple vessel disease, even if the patient is stable, at least the critical stenosis should be treated. And of course, because they stabilize the plaque much more than medical therapy alone can do. Thank you very much. And finally, I invite you for our Indo-European conference, which is being held in 21st of December 2023. This 20th chapter, which we are doing, we started in 2008. And then we did London, Rome, Paris, Amsterdam, Zurich, and then of course we are doing in India. I invite you all if you can join this place. Thank you very much.
Thank you, Dr. Vivek. Now I invite Professor D.V. Pehlajani, the one of the senior-most cardiologists of the Cardiological Society of India, previous president of Cardiological Society of India, to talk on a very important topic of multivessel CAD with LV dysfunction.